Hello everyone and welcome to my learning space. Today we have a case of a 52-year-old gentleman with risk factors of diabetes and hypertension who presented with chest pain and dyspnea, clinically in heart failure. When presented to ER, troponins were elevated, and that's the echocardiogram. So the basal to mid-intro septum is contracting normally. The basal infralateral segment is also contracting normally. There's no significant MR or AR. However, looking at the basal infraseptal inferior segments, so these are akinetic. The apical 4-chamber view confirms basal to mid infraseptum, and the apical 2-chamber view confirms the basal inferior segment being akinetic. Some more views. So that's the akinetic segment we're talking about. However, on different views, we could not appreciate any color flow across the interventricular septum. So obviously a patient with heart failure and acute myocardial infarction, we wanted to look for mechanical complications. So there was no MR, so we're trying to find a VSD. Mild MR. So in a short axis view, we had suspicion of a flow across the interventricular septum. So we went to the subcostal 4-chamber views. You can see mild to moderate TR. And there you go. We were able to identify a flow across the interventricular septum. So it's very clear here. That's the defect and that's the flow across it. So this patient had a VSD complicating the acute myocardial infarction. The gradients across this VSD were 104. So if this patient had systolic blood pressure of 120/70, could you use this to calculate the RV systolic pressure? Yes. So the VSD jet can be used in these cases. The continuous wave Doppler of VSD was giving us gradient of velocity of 5.11. So using this equation and then subtracting that value from the systolic blood pressure would give you RV systolic pressure. In this case, we did it and we found an RV systolic pressure of 15 mmHg. And an obvious view of flow across the VSD. That's all. Thank you. Please do like, share, and subscribe.